Hi, everybody. Thank you so much for coming in person and tuning in online. Welcome to Loma Linda University Health Clinical Ethics Grand Rounds, brought to you by the Center for Christian Bioethics. My name is Grace Wee, and I'm honored to serve as the director of the center. The Center for Christian Bioethics is entering its 40th year of service, and I'm excited to continue the center's strong tradition of uniting service and scholarship through our programming and our academic work in teaching and mentoring, and through our sponsorship of scholarly projects in collaboration with other schools on campus. Our calendar events for the current academic year will be published shortly on our website. So I want to invite you to go to our website. It's on this banner. It's down at the bottom, bioethics.lu.edu. I also want to acknowledge and thank our center manager, Migella Velasco. Wave hi, Migella. Thank you so much for her work in putting together the logistics of this program. We're very blessed to have you on our team. Thank you. And before I introduce our speaker, there's just a few housekeeping items. For those of you online, please post your questions in the Q&A. We will address them in the Q&A portion after the talk. We're reserving about 10 or more minutes for the Q&A portion. For those of you who are in person, we'll have this microphone available for you to ask your questions. Additionally, this talk will be posted to the center website afterwards, so please spread the word to your colleagues who are unable to join us here today. And finally, this conference is approved for CME, so in order to claim your CME, please go to eads.com and sign in. Information is also available on the chat for those of you who are attending online. The conference code is 00BAAL, or I would pronounce it BAAL. So I'm not sure who actually comes up with the conference code, but I thought it was appropriate, as Baal is actually used in the Hebrew Bible to refer to the Canaanite Phoenician god of fertility and rain. Considering the weekend we all have had, I think we might be forgiven to wondering if Baal has had some sort of sick sense of humor. All joking aside, I hope you and your loved ones have come through safely. These are strange times when we as Californians must contend with hurricanes in addition to earthquakes. But it's in times like these that people's thoughts turn to preparing for oncoming disaster. And I can think of no better segue into our topic for today, advanced directives and POLST forms. For these are powerful tools for preparation for ourselves and our patients. Especially, as Dr. Mohr said, life has a 100% mortality rate. And to help us prepare, I'm honored to introduce our speaker, Dr. Gina Mohr. Dr. Mohr is an alumnus of Loma Linda University School of Medicine. After graduating, she trained in family medicine and palliative care. She founded the palliative care program here at LLU and continues as its director. Loma Linda University's palliative care program offers integrated palliative care for both adults and pediatric patients, and a fellowship program in hospice and palliative medicine. Dr. Mohr also serves as a clinical ethics consultant. She chairs the ethics committee for both the Children's Hospital and the Medical Center and regularly leads out in our Schwartz rounds. Alongside her long list of achievements, Dr. Mohr is known for her empathic bedside manner, her pearls of clinical wisdom that students and residents call Dr. Mohrisms, and the way that she encourages her team and learners to explore their personal wholeness journey while caring for their patients. In my work in ethics and pediatric critical care, I've learned so much from Dr. Mohr. I have leaned into her wisdom time and time again. And one thing that I appreciate about Dr. Mohr is her incisive wit, which she uses to diffuse even the most tense of situations. Most of all, I'm honored to call Dr. Mohr my friend, so please join me in welcoming Dr. Mohr.
Thank you, Grace. Thank you for that very kind introduction. I don't think I've ever been introduced in the same paragraph as a hurricane, so that's something new, or as upcoming disaster. I don't know what that signifies either, but that's okay. So advanced directives and POLST forms are something that's really, really important to understand. Grace asked me to do a very clinically oriented practical talk on this. She probably did that because she knows that I'm really not a philosopher, as some of my other folks in ethics are. But having a conversation about these things is so important, and often something that does not occur. So that's what we really want to talk about today. So we want to understand the importance of having the conversation, identify the importance of advanced directives, what they are not, the misunderstandings about them, and also know how POLST forms complements advanced directives. So it would be nice if we could say that medicine could fix everything, but we know that medicine is not able to fix everything. And sometimes we have patients who come to Loma Linda who are hoping for cures and treatments that may not be possible anywhere, whether they go down the street to City of Hope, to UCLA. But we seem to think that there is the potential that life-saving therapies can keep just about anyone alive. But unfortunately, the reality is that we can't fix everything. And so then the question is, what then is our obligation? So it is true that from the dawn of time in all of recorded history, 100% of us will die. Those of you who are theologians and know the story of Lazarus, you know that Lazarus was raised from the dead. Lazarus is no longer here, though. So even Lazarus died a second time. So the question is, how do we want that time to be, right? And Atul Gawande talks about, if you knew your time was short, how would you like to spend it? So there is the challenge then of looking at a person, looking at a patient, and having different perspectives, because where we draw the line between prolonging life and prolonging the dying process often differs between different family members and patients themselves, right? So with this, I thought it would be helpful to think of someone who just came into the news again over the weekend that I read about. Jimmy Carter was president from 1977 to 1981. And the interesting thing is that under his leadership, Congress actually passed the Medicare hospice benefit. So hospice became a thing, right, in the US, a formalized, specific insurance benefit that hadn't existed before. Hospice was built from grassroots efforts, mostly nurses who said, hey, can't we have some sort of a system that helps take care of dying patients who want to be comfortable, who want to be at home? Well, interestingly enough, Jimmy Carter enrolled in hospice in February of this year. That is 6 months ago. So he should be up for what we call recertification, right? So we think of hospice for 6 months, and if someone continues to decline after that 6 months time, they get reassessed, and if they meet qualifications, which means they're continuing to decline, they can get put back on hospice for really unlimited time periods. So I think Jimmy Carter's story is a very encouraging story because the average length of stay on hospice in this country is about 18 days. So if you think about the benefit, that it could be for 6 months or more, but most people don't get on hospice until the last 2 or 3 weeks of their life. So I want to share with you the Conversation Project. This is a project that Ellen Goodman and others started back in about 2011. And I want to share with you a video, and hopefully this video will work. I'll let you handle the reins here.
I started the Conversation Project while I was going through my mother's own last years, months, days of life. We had never talked about her wishes for end-of-life care. From time to time, she would say something like, if I'm ever like that, pull the plug. But of course, when she became ill, there was no plug to pull. And also, my mother had dementia at the end, so we were not able to have any conversation about what her wishes were. So I was her healthcare decision maker. And in the last months, years, really, I had a cascading number of decisions to make for which I assure you I was totally unprepared and, in fact, blindsided. What I learned from the experience of talking about my mother's end of life is that, guess what? This experience is far too common. Far too many of the people we love are not dying in the way that they would choose. Far too many of their survivors are left guilty, depressed, uncertain about whether they have done the right thing. 70% of people say they want to die at home, and 70% of people are dying in hospitals and institutions. That's just a huge disconnect between what people wish and what happens. We can change that. That's why the Conversation Project emphasizes having a talk about values, about what matters to you, not what's the matter with you, but what matters to you and what's important for you to think about at the end of their life. Are you a person who wants all the information, or do you want just enough? Are you someone who is going to make all decisions for yourself, or do you want your family to be involved? What's important to you at the end of life? Then you've given them a real staff, a guide. We started the Conversation Project with just a small group of people around a table. When we sat down, we brought in experts in the field, and it was the experts in the field who told us that if we're going to change the way people die in America, we have to go outside the medical system and change the cultural norm from not talking about what we wanted at the end of life to talking about it. One of the things that the conversation does is tell your parents that you're going to be there for them, that you're not going to leave them isolated in the hands of strictly medical people. The medical community is just beginning to be conversation ready. A generation ago, we transformed how people were born. It was not the medical profession that said, come into the hospital with your video camera, let's have a baby in a bathtub, and don't all the husbands want to come into the birthing room? It was not, I assure you. Birth is a human experience, not just a medical experience. And part of what we're doing in talking with people is recapturing and saying, dying is part of the human experience. It's part of a natural progression in life. We have the capacity to transform how people die in this country. I think everybody does have an idea of what a good death would be. When you ask people, the word that comes up the most is peaceful. The Conversation Project is very much about connecting. It's about sharing, and it's about being open and loving to each other through a very difficult journey.
Now, hopefully this won't start playing something else. So we will go here. So many people think that advanced directives are really just for a geriatric population, right? I don't need to worry about that. I'm young, I'm healthy, nothing's going to happen to me. So I want to illustrate
the
with
only
a case.
challenge, I think, with addictions is
And
that
it did
if you
start,
can't
didn't it?
think greater than how you feel, your life will stay the same.
Yeah.
The solution then is...
There we go. There we go. That's perfect. Perfect. So let me tell you about Donna. Donna's a 35-year-old woman with metastatic cervical cancer. She was diagnosed a couple of years ago, had chemo and radiation, and she remained disease-free for about a year, and then she developed a recurrence. She's currently getting chemotherapy and immunotherapy, but despite that, her cancer is progressing. So she is married. She has 2 teenage kids. She has parents and siblings who are nearby. She describes herself as Christian, but not actively going to church. She worked in a fast food restaurant until about 3 months ago, and now she's on disability, and she's been very worried about her finances. Husband's been having to take some time off to help take care of her as well. So would it be helpful then for Donna to have an advance directive? Well, let's talk about advance directives. They're really a document that helps make your wishes known if you cannot communicate. Doesn't mean that you have to wait until you're very, very sick. And in fact, I would argue that people who are in kind of the prime of their life, younger folks who are at risk of having a major disaster out on the 10 or 215 freeway, you have a significant brain injury, you never wake up again. I would argue that those are the folks who actually have the most to lose. So if being maintained in a state where you have no interaction with your environment, can't talk to family or friends, if that would be okay, then do nothing, because that's probably what will happen. But if that's not okay, then you actually have to talk about that and say, no, that's not something that I would want. So advance directives do two things. You can name your wishes, and then you can also state someone who can help communicate those wishes for you. Now, I will tell you that if every member of your family showed up at your bedside and they all said, we know exactly what Donna would want, and we're all in agreement, and this is what we should do, you do not need a document. You can just forego that part, right? But how many of us have families that are that functional, right? How many where everybody in the family agrees, everyone is on one accord? Often not. That's often the reason that Dr. Wee and I get called for ethics consults, because there's some sort of conflict, there's disagreement about what to do. So if you have family members who you know would disagree either with you or with each other, then that's where a document can come in very, very handy. If there is a conflict and nobody can really say what this patient would want, typically we just go ahead and go along with the person who is demanding more stuff until the family can kind of figure it out and say, okay, this is what we as a family would like to proceed with. And again, really the focus should always be on what would this patient say if they could be with us right now, right? Because sometimes families will say, you know, I know Dad would never want this, but I can't make that decision. I tell them, that's not actually the decision for you to make. You're here to help us know what Dad would say and how Dad would feel about this. So there are different forms. There are lots of different forms. You can find them on online. There are state-specific forms. There are kind of more general forms that have been developed by different companies. Actually, the one that I like is the low literacy form that you can find on Loma Linda's intranet if you go to forms there. And it uses very simple language to explain what it is, has little tiny pictures, and it kind of walks you through how to complete this. The other thing I really like about the low literacy form is it asks you, think about what is important to you in life. And then it has a list of things. Which of these are important for you that if you could not do them, you would say, I don't want to be maintained in this condition. So it talks about things like being able to talk to my family, being able to live off of machines, being able to be as free of pain as possible. So how important are those things? Because I think a lot of times people don't even realize that we can keep them in a condition where they are not able to talk and interact with their family, that they have no idea that that is something that might be in their future. So who can complete advanced directives? Anybody 18 or older. That's it. That's the only requirement you have to have. So if you think about it, that's a lot of people. So what percentage of Americans fill out advanced directives? It's actually less than a third. Usually those are folks who are older age. They're often looking at things like planning for other things as well, such as estate planning, planning wills. So really talking about their kind of material wealth and not necessarily about their health care. It's often done with attorneys when they're doing this estate planning, which attorneys are great for certain things, but not for healthcare. They actually don't understand kind of the nuance of what these things mean. So who should you choose? So choosing an agent is a really important thing. I talked to a gentleman last week who was hospitalized. He actually looked he looked younger than his stated age. He had come in for some cardiac arrhythmias. Cardiology thought that they would get that fixed pretty quickly, and hopefully he would go on his way and live his life and do well. But I asked him, I said, if you got so sick that you couldn't talk to your doctors, have you thought about who you might want making your decisions? And he said, oh yeah, I've thought about that. I've actually been working on my advance directive. And I said, well, who would that person be? And he said, that would be my son. And I said, well, that's great. Have you talked to your son? Oh, no, I haven't talked to him. So it's fantastic to have someone in mind, but then the next step is actually to talk to them and let them know. I've had family members who say, you mean I am the one who's named in that document? I don't want to be that person. I don't want to make any decisions. So it's good to talk to your agent to make sure that they're willing to make those decisions, and then to actually have a conversation about what your wishes are. If you name someone and you don't talk to them and give them some information about what's important to you, that puts a lot of the responsibility on them, which I would argue isn't really fair to them. So usually these folks are a family member, but sometimes they can be a friend. And in fact, sometimes I've had advance directives that will say things like, absolutely do not ask my brother about any decisions. I do not want him making any of my decisions, right? So you can put in an advance directive who you don't want making decisions, but it is more helpful to actually tell me who you do want making decisions, right? And a couple of the things that also is important to know, you can't name your physician. So maybe you've been seeing a doc for 20 years and you say, my doctor knows me, let's have them make that decision. You actually can't do that. And it can't be the employee of let's say a skilled nursing facility where you are now residing. So again, you must talk to your agent, and you need to make sure that they know what your wishes are. But the other important thing that agents need to know is that it is the agent's job to communicate your wishes, not their own wishes. So I have had cases where I have patients who have a very, very clear advance directive that says something like, absolutely under no circumstances should you intubate me, even if you think this is a reversible condition, and intubating me would just be for a few days to treat something that's reversible, and then I could go home with my family. If they say that is absolutely not acceptable, I would not want to be intubated even under those circumstances, and then the agent comes along and says, yeah, I know, but I don't really care what Gina said. This is what I want to do. I want you to intubate her anyway, because I think after a week or two, we can get her home. That is actually not the agent's job. That agent is actually reneging on their responsibility. What their job is to say, you know what? Gina said this is what she wants. I think this is a bad idea. I don't agree with it at all. It's not what I would want, but I know that's what she would want. And I'm telling you that so that you know what her wishes are. That is a really good agent. Another really good agent is someone who says, you know what, all my brothers and sisters, my 11 brothers and sisters are all really, really angry at me because they want to keep mom alive on this machine, but mom told me she didn't want that. I have this paper right here that says that. Mom named me, and we are turning that machine off. So that person now has to face kind of the wrath of their family. That's kind of a hard position to be in, right? But think about what a good agent that is, right? To be able to stand up to family members who are angry at you and say, no, 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 this is what mom would want. So that's what the agent's job is. So if you ever are in the situation where you have an advance directive that is very clear and the agent is wanting to do something not in accord with those wishes, that is not the agent's prerogative to do so, okay? So a word about terms. So I hear terms thrown around all the time that maybe aren't quite accurate. So these up here can actually be interchangeable. So a power of attorney for healthcare, or a medical power of attorney, or a healthcare proxy, or a healthcare agent, all of those are basically the same thing. And by definition, it is the patient has named this person to be their power of attorney for healthcare, their medical power of attorney, their healthcare proxy, right? What often I hear sometimes is a patient has lost capacity, they never appointed someone, and I hear someone on the team saying, who should we make be the power of attorney? Well, you can't. If that person now does not have capacity, you're out of luck, right? That's only something that a person, a patient, can do when they have decision-making capacity. So then you say, but we ask families all the time. That's correct. So if you have not filled out a document, if you have not named someone either in writing or verbally, then we kind of turn to whoever shows up at your bedside. And again, if all 23 of your family members show up at your bedside and they all say the same thing and they're all in agreement, then that's what you do. But often it's this one says do this, and another one says no, 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 let's do that, and a third one says I have no idea, and then you're not sure what to do. So Donna shares that her husband and parents disagree about what to do, and she doesn't want to make any of them angry, right? She loves them all, and she's been working on completing an advance directive. So, you know, what's very helpful when you're thinking about advance directive is that they really should be based on values and should be based on what is important to you to be able to do, and will this intervention help you be able to achieve that? So unfortunately, the healthcare team often says things like, do you want the trach? Do you want a PEG? Do you want blood? Do you want dialysis? Without telling you what that actually entails, what that means, what will that mean for my quality of life? What will that enable me to be able to do? So more importantly, it's what is so important that you need to be able to do it, that you say, I will take that if I can do that, right? I will take being intubated for a week or two if you think that during that time you can get me better to the point where you can get that tube out, get me off the machine, get me home to spend a little bit more time with my family, right? Some people might say the most important thing in my life is being able to eat chocolate ice cream. And if I can no longer eat chocolate ice cream, I don't care if you can put a tube in my vein, my nose, my stomach. If I can't eat it by mouth, I don't want any tubes. So again, it's not the tube that is important. It's what does that tube help you be able to achieve? What gives your life meaning and purpose? And can these interventions actually help that? So if you look at, I believe this is actually one language from the low literacy advance directive, but it will say kind of vague things like this. I do not want my life to be prolonged if, number one, I have an incurable and irreversible condition that will result in my death within a relatively short time. Well, that's pretty straightforward, right? You got that down. So clearly, if I have a stage 4 pancreatic cancer, and now I come in with an infection, and I can't communicate, then obviously I don't want my life to be prolonged. But maybe a doctor says, but wait a second. We might be able to not cure your pancreatic cancer, but now you've got an infection. You've got a urinary tract infection that's led to sepsis. We can actually reverse that. And it might actually be reversed within days of IV antibiotics. Are you sure that's not okay? So some docs would say, this meets criteria, don't intubate, don't put them on pressors, don't put them in the ICU. And another doc might say, but wait a second, this infection's reversible. And, you know, what's a relatively short time? Is it days? Is it weeks? Is it months? So the problem with advance directives is they're always open to interpretation, and we often don't know how to interpret them. And that's why it's really important to have an agent that can help us know exactly what this person meant and whether or not this would be a condition that they would say, go ahead and do all these things, or this would be a condition that they would say, no, just focus on keeping me comfortable, right? So number 2 is I become unconscious, and to a reasonable degree of medical certainty, I will not regain consciousness. So think about people with intracranial bleeds, with massive strokes, maybe even with a traumatic brain injury. So how certain is a reasonable degree of medical certainty? And what if I have a neurologist and a neurosurgeon totally disagreeing, right? Neurosurgeon says, yes, I think they're going to get better. The neurologist says, no, I don't think so. Who do I listen to, right? So that's a challenge. And 3 is probably the most vague, right? The likely risks and burdens of treatment would outweigh the benefits. Well, that's very subjective, right? So the risk and burden of being in an ICU with lots of lines and tubes and having monitors going off and not getting sleep and being afraid and being in pain, is that worth it? And I might not know that unless I can talk to this person's agent to help me understand what they meant by that, right? Or the other option is I want my life to be prolonged as long as possible within the limits of generally accepted healthcare standards. Well, that's pretty straightforward, right? Until you try to find out from 5 different doctors what are generally accepted healthcare standards. right? So the ICU team has a patient who has been very, very sick. They now have a trach, and but they are not able to swallow. They've had an NG tube for a long time, and the ICU team calls GI docs to put in a PEG tube. GI says, this person isn't waking up, we're not going to do it. So then the ICU team calls the surgery team. Can you put in the PEG tube? The surgeons say, oh, this patient, look, they haven't been awake for the last 2 months. We don't think that's a good idea. So then the ICU team calls the interventional radiology team, and the interventional radiology team says, we don't think that's a good idea. So now what do you do? So the problem is, it sounds good to have generally accepted healthcare standards until we come to a spot where we're not really sure what those are, right? And that you will get different opinions from different teams and different doctors within that team. So the low literacy form is the one I really like. Witnesses. So you do not have to see an attorney to have an advance directive. All you need to do is have 2 people sign it. It can't be your agent. So one of your witnesses can't be the person who you're naming as your surrogate, your power of attorney. Can't be your physician. Can't be the owner, operator, employee of a facility. And at least one cannot be related or entitled to gain from your estate. So do advance directives expire? They do not. If you complete a new one, it's whatever one is completed most recently. And you can verbally revoke these at any time, as long as you are able to speak or communicate in some fashion, right? So once you've completed your advance directive, well, now what? So then it's really important to make copies, make sure your physician has it, make sure the hospital where you're probably going to end up has it, that your family has it. We say keep one in your car just in case, and they probably need to be updated periodically. So coming back to Donna, her cancer's getting worse. She gets hospitalized for sepsis. She develops respiratory failure. She's on high flow oxygen, but the team is saying, you know, she might need to be intubated soon. She never quite completed that advance directive that we sent home with her. She kind of started on it, but never completed it. You get the family together, and the family disagrees. Husband says, you know, I want her to be full code. The parents say, no, 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 I don't think she'd want that. Let's make her a do not attempt resuscitation. And her healthcare team wonders, what in the world should we do? Who should we listen to? She can't talk to us. She didn't write anything down. And we have family that says we disagree. Well, some people would say, oh, husband is the next of kin. Don't we listen to him? Well, not in the state of California. Maybe Tennessee, Oklahoma, some other states that actually have legal hierarchy, but not here. And in fact, in January of this year, there was a new law that was passed that allows not only family, but friends, caregivers to actually have legal authority to make decisions. Okay, so it says if a patient lacks capacity to make a healthcare decision but does not have a legally recognized healthcare decision maker pursuant to subdivision A healthcare provider or designee of the healthcare facility caring for the patient may choose a surrogate to make healthcare decisions on the patient's behalf as appropriate in the given situation. So clearly, if you have an advance directive, if you're conserved, you go with those things, but very rarely do our patients have that. So then it goes on to say the patient's surrogate shall be an adult who has demonstrated special care and concern for the patient, is familiar with the patient's personal values and beliefs to the extent known, and is reasonably available and willing to serve. So in California, there's nothing that says, oh, we should listen to the husband and not the parents. In California, it says, listen to everybody and then figure out who actually has this patient's best interest at heart, right? So what we often in ethics say, who is it that knows you the best and loves you the most? But be careful with that, because sometimes the person who loves you the most is least willing to follow your wishes, particularly if your wishes are not to be around forever and ever. So we have a family meeting. The husband really is focused on, you know, the kids. How do you expect your kids to live without their mom? We need to do this for the kids. The parents say, you know, I don't know that I trust him. There's been reports of domestic violence, so I don't think he's really the most upstanding guy. Neither can really say what the patient would want. And then a very good intern goes digging through the chart and finds a note that says this. Donna understands her cancer is getting worse and wants to plan. She has said she doesn't want to die at home in front of her kids. She actually had an aunt who died in the ICU, and she thought it was not a comfortable, pleasant experience. So she doesn't want to have CPR or end up in the ICU. So that was from a clinic note that was found. So now, with that information, we gather everyone around together again. And Donna her code status is changed to do not attempt resuscitation, selective treatment. She actually improves with IV antibiotics, right? Which is not too unusual. People often with a serious advanced illness sometimes comes in with something that is acute, reversible, and can get better. Clearly, she still has her advanced cancer. She's able to wean off high flow, and she's actually able to get discharged. So now that Donna has been a do not attempt resuscitation in the hospital, then the question is, what happens when you discharge her? So every single one of us, I would imagine, unless you are carrying a hidden POLST form in your back pocket, but I doubt it, every single one of us is a full code, as are most patients. So if you have someone who you've actually have had this conversation, you've confirmed with the patient, she does not want a resuscitation, she needs a POLST form, right? So POLST stands for Physician Orders for Life-Sustaining Treatment. We know that CPR is one of those things that is probably the least effective, least efficient thing that everybody gets when they're dying, unless you make a plan for that not to happen. What often people don't realize is that if you take all comers in a hospital like Loma Linda or nationally, only about 15% of them will survive to leave the hospital alive after being coded. That's all comers, though. That's kids who were hit by a car on their bike. That's a healthy young woman who just had a postpartum hemorrhage. That's everyone. If you narrow it down to the palliative care population, so people with known advanced illnesses, right? Advanced cancer, heart failure, lung failure, renal failure, chances of surviving after code is less than 1%. So CPR just isn't very helpful. And the problem is because CPR doesn't fix anything, right? CPR only buys you time to figure out what the problem is and then treat it and reverse it and fix it if you can. But if you already know that you can't reverse that underlying problem, not very helpful. So POLST actually is supposed to help encourage people to have conversations. And really, we say it's for patients who already have a serious advanced illness. So advanced directives for everybody. POLST is really for people who are now dealing with something that is more advanced. POLST does not replace advanced directives. It really complements them. There are many patients that I have who I'll be having a conversation in clinic and they'll say, oh yeah, I've already said that I don't want to be resuscitated. That's in my advanced directive. And I say, great, that's not enough. Because paramedics will not follow an advanced directive. They can't. An advanced directive is for the physicians. So the paramedics will move your family nicely aside and say, excuse me, I'm going to do CPR and I will take your advanced directive with me to the emergency department. So the difference, right? If you compare and contrast a living will or advanced directive with a POLST, living will is really for anyone. It requires you to think about lots of different situations. You can state your preferences based on values. Then you need to find it, right? Most people, they have it in a safe somewhere. It's locked up or no one can get it. And then it requires interpretation. The POLST form, on the other hand, is for people who are seriously ill. It's very clear decisions among these very identifiable options, and you check a box. And it is supposed to stay with the patient no matter where they go. So it's a bright color in the state of California. It is pink. Up in Oregon, I think it's yellow. Washington is green. But it's supposed to be a bright color so that when you get brought in from a nursing home and you have a stack of papers that thick, you can see something that looks pink and pull that out and say, that's the most important thing for me to look at. So it's actually a physician order to be followed. So if I complete a POLST on one of my patients here, they go to a nursing facility and then at midnight, 911 is called and they go to another hospital where I am not on staff. They actually can look at that POLST form and say, this is a doctor's order. And even though Dr. Mohr isn't on staff here, we have to follow this. So it's a legal document. Took place, it's been now since 2009 in the state of California. It's had a few revisions, but really the basis is to encourage a discussion. Everything, whether it's an advanced directive or a POLST form, it's all about the conversation. And again, if that conversation is really, really good, you probably don't even need a document. Okay. So the document is just the outcome of that conversation. So what does it look like in the state of California? It's bright pink. It has several different sections. Section A is pretty straightforward. If I have no pulse and I am not breathing, I am dead. And what are you going to do? Are you going to attempt a resuscitation or not? Many of my patients say, oh, if I died peacefully, comfortably in my sleep, just leave me alone. But box B gets a little trickier. Box B, I have a pulse. It's not great. I'm breathing, but not super. I'm having a hard time. So am I going to be full treatment, selective treatment, or comfort focused treatment? Full treatment basically means you're going to get the works, right? You will get intubated. You will go to the ICU. Selective treatment might be like Donna. Donna says, I'm okay with going to the hospital. Do not code me and do not put me in the ICU, but give me some antibiotics, give me some fluids, see if I get better. Comfort-focused treatment is very hard to do unless you're on hospice, because who do you call if you're not going to call 911, right? So that's important to make sure people understand that. Section C, we could do a whole nother grand rounds in the future, Grace, on nutrition and hydration, because I would argue it is the hardest thing to talk to patients and families about. Families, it's this very emotional component when their loved one is no longer eating and drinking. How then do they show that they love them and care about them? That's what we have to help families with. And then finally, summary and signatures. In California, it has to be a licensed physician, NP or PA, and either the patient or their surrogate can sign for it. So again, it's this kind of standardized practice. We've trained people on how to complete POLST and help physicians know what to do with them when they show up in the emergency department, and it really should be honored across the healthcare system. So who needs a POLST? Really, the question we ask is, would I be surprised if this person died in the next year? Have they had an illness, something that is progressing that we think, I wouldn't be surprised about that. So we need to have a conversation, and then based on that conversation, complete a form. So Donna completes a POLST. It's do not attempt resuscitation, selective intervention. She doesn't want any tubes. We talked about how probably artificial nutrition won't help in her case. She can eat. She doesn't feel like it because of her cancer. She's okay right now with returning to the hospital, but she is thinking about hospice, and she's met with them, but hasn't quite gotten ready yet. And then she gets admitted again for another episode of sepsis and now some renal failure. And this time she says, I'm done. I don't want to come back to the emergency department anymore. I want to be comfortable. So she elects hospice at a skilled nursing facility. And because she has Medi-Medi, she can do that. Sadly, many of our patients who don't have both Medicare and Medi-Cal can't get a hospice at a SNF and have them both covered because of insurance. And her POLST is now updated to reflect do not attempt resuscitation and comfort care. So I want to show you one more video because I think it kind of shows you what can happen with family members and having a conversation. So if I can find my little, there it is. Let's play this.
And finally tonight, ABC News wants to join you in something right at the heart of the American family. How we can all help the people who care about us make decisions near the end of our lives. And 9 out of 10 of you have told us that we should all be talking about it at all ages, what we want. And yet only a fraction of us have done it. And we know it makes a huge difference in the health of the caregiver as well as those cared for. So ABC News has taken cameras inside a vital, loving family, part of a new community, deciding to have the conversation.
This is 85-year-old Norb and his daughter Maureen.
My dad is 85 today. He's still very, very active. He's a wonderful friend.
Throughout life, daughter and father have always talked about everything, except one thing: how to control the end of your life in the same way you control the prime of your life. So dad and daughter gather the family together, 3 generations, for an act of love.
And so now we're just asking that you share some of your thoughts about what you would like at the end of your life, so that we can honor your wishes.
They are part of something new underway for families in America that says having the conversation is a gift parents and children give each other. And there's proof of the difference it makes. Studies show depression rates plummet after a loss if the families have had the conversation. Renowned physician Dr. Atul Gawande says doctors and nurses see it firsthand.
When you're there in that moment and you're talking to the family and you're saying, how much will it bother your father if he ends up this way? And they say, more often than not, I don't know. We never talked about it. That it is incredibly traumatic for the family, for the doctors involved. There's often conflict. It can tear families apart.
So Dr. Gawande has become part of a team led by Pulitzer Prize-winning writer Ellen Goodman. It is called the Conversation Project. It is a kind of guide for families looking for a way to begin.
If we give them a way to talk about it and give people something to hang on to when they're afraid to start this conversation, they can do it and pass it on.
Families like the Jennings. They looked over the conversation guide before they sat down together. First, there's laughter.
My golf swing's still good.
And then Dad directly eases his daughter's guilt and worry about having put their mother in hospice.
I felt like that meant we were giving up on Mom.
She was in a lot of pain, and I think it was handled real well.
And next, Maureen asks her dad for clarity on what he considers a good end to a great life.
So if you were in a condition where you couldn't make decisions for yourself, how extreme would you want us to take measures to save your life versus letting you go?
Well, I think I'm ready to go anytime. You know, I wouldn't prolong anything. I mean, I've lived a great life. Pretty lucky. And because of you guys, you know. And
unexpectedly, a grandson is inspired to speak up about his own wishes for his own life.
That if there was no meaningful communication, that I would want you to stop trying to intervene.
we aren't ready for you to go that soon.
Well, we're not ready for you to go that soon either, so.
One by one, the others weigh in, all ages.
Don't do that.
Happy birthday, dear Grandma.
And with that, another family has joined a kind of estate planning for the heart.
Go.
The conversation beginning in America. So please tell us your stories in the days ahead about ways to begin the conversation with family members of all ages. Or if you don't want to have it, tell us about that too. My colleague and my friend, anchor Bill Ritter from WABC, and I will be reading your emails and looking at the great photos you're already sending us of your families. So go to abcnews.com, find the conversation and the guide.
All right. So having a conversation is so important. So as we're coming to conclusion here, advance directives can help document your wishes, right? Agents help communicate those wishes. POLST forms turn those wishes into orders. It is only as good as the conversation that is held. And I will tell you that we are about 4 months away from Christmas. So one year, my in-laws asked me, Gina, what do you want for Christmas? And I'm thinking, my house is overflowing. I have enough kitchen implements. I have enough towels. There's really nothing that I want. But realizing that my husband is the oldest kid, I realized that he would probably be the one that would have to make decisions. So I actually asked my in-laws, I said, I think a really great thing for you to do would be to complete your advance directives and talk to my husband about what you would want. And fortunately, my in-laws are both in healthcare, so they didn't think it was too odd. But they said, okay, that's weird, but okay, we'll do it. And they did. And so they have their advance directives done. So here are some resources for you to take a look at. There's a POLST website that you can go to. And with that, I am going to open it up for questions. And Grace, I'll let you kind of lead the way on that.
So much. Let's give Dr. Mohr a round of applause. Thank you so much. For those of you who are attending online, please go ahead and post your questions in the Q&A. We have some questions here. And then also, so we'll take a question from online and then we'll ask what questions are here in the audience. So Dr. Mohr, what advice would you give on how to handle situations when we have a healthcare proxy that is making decisions that are against what the patients stated or what their documented wishes are? But the healthcare proxy is insistent on not abiding by what the advance directive states.
I think, like I mentioned, if the advance directive is truly, truly clear, irrefutably clear, and the agent is going against that, I think I would say, I'm so sorry. This is what this document says. It's a legal document. I'm going to follow it. And if they then want to go and seek legal intervention, they can do that. But right now, I'm legally responsible for following that advanced directive. On the other hand, like I mentioned, many advanced directives, they are open to interpretation. So is it just that they're interpreting it one way and I'm interpreting it another way, and maybe it's a time-limited trial of something? So it really depends on how specific that document is.
So for example, if a patient comes in with a previously filled out POLST, say, we've got a California registry that has POLST forms that can be scanned in. So say you find a patient's POLST and it seems 3 or 4 months ago and they've requested DNR and it's signed by the patient, but the patient's agent is saying no, full code. Then at that point, since you have a pre-recorded wish, would it then be ethically appropriate, because we don't dispense legal advice, but would it be ethically appropriate then to inform the agent that no, we are going to be following the patient's wish for DNR?
Yeah, I mean, I'd want a conversation. I'd want to know why do I see this form and why are they telling me something else? Why is there that disconnect? Because there's often a story behind that. But yeah, if I have a POLST that a patient signed and it looks appropriately filled out, that's what I'm going to go off of. The reason we do that is because we have actually had cases where we have POLST forms on file, and then when the patient comes in, their family member has actually taken the POLST form off the refrigerator and hidden it from the paramedics who come in and have not wanted them to see that because they didn't want it followed. And yet we have it on file here. So, again, lots of emotions in these situations, but really at the heart of it, we want to try to honor the patient's wishes, even when that might not align with what the family's wishes are.
Thank you. I see a hand here.
Thinking back just a few weeks ago when both of you were in a conversation and another physician kept on talking about, convincing the patient of the facts. And both of you were just very nuanced and incredibly effective at saying, it's really more about the conversation, which is what happened here. Question I have, maybe partly a comment, partly a question. I've just been asked to help develop a bioethics course that would work with the genetics counseling program. And then because it's a small program, which hasn't started yet, there was a suggestion that we combine it with another program where the students are working in a profession where they won't interact with patients at all. And I was thinking, wait a minute, I don't think that's totally the right way to do it. But it did raise, First, I just want to applaud your emphasis on the conversation, because so many of these things are ambiguous for all sorts of reasons. And we're dealing with human beings. We're not, this is not repairing a car. But I was wondering, does the Conversation Project deal with other kinds of conversations other than just end of life conversations? And any thoughts you might have, say, genetic counseling, for example. I'm not totally sure what all range of things they will be covering, but I'm just curious, is this something that applies to a variety of different patient conversations?
That's an interesting question. I think the Conversation Project is more directed towards end-of-life care. But, do we have conversations about other things that are important? And I think absolutely. And what springs to my mind is, if you get a genetics testing that says your child will have this serious condition, let's say trisomy 18. So you might know the facts of trisomy 18. They have this, maybe profound intellectual disability, maybe a shortened lifespan. But then what you do with those facts, right? The emotional part of that is the other part that I think is where ethics fits in, and not making assumptions about, oh, these are all really bad things, so therefore this quality of life is poor, so we shouldn't do lots of interventions. That does not necessarily coincide with how the parent feels. And so I think it's important to say, these are the medical facts that we can share with you to the best of our ability. But now, how do you see those? How do you interpret those? What do those mean for your life? That's a very different discussion. And I think it is about a conversation. Yeah.
Thank you so much for that. This is a question that's coming in. I would like to hear your approach to disagreements among the healthcare team, for example, the primary team, or more troubling, a trainee with a closer relationship with the patient. So say the team thinks the patient is ready for the talk, but a crucial consulting team like oncology wants to press on and seems to imply that talking about end-of-life options is off the table.
So I think that there are sometimes differences of opinion among healthcare teams. And I think that, again, I think it's a conversation among the team themselves to figure out what are they worried about. It's no different than a family member saying, don't tell daddy he has cancer because he's just going to fall apart. I want to know more about that. I want to hear more about that. So I think it is a conversation among the teams. I think there is this fairly widespread idea in medicine that if we talk about anything, that it means if we talk about, oh, what if chemo doesn't work? If we bring up hospice, it means we're giving up, kind of like the daughter in the video that, the dad said, I think hospice was appropriate, right? So I think there are ways to have that conversation that are less threatening than others. I think it's kind of about, listen, I'm hoping, Donna, that you get stronger, that you get better. And if you want to go back and see your oncologist and get more chemo, I'm rooting for you. But can we talk about a plan B? If that doesn't happen, and I haven't said it won't, but if it doesn't, can we talk about what happens if you're not getting stronger, not getting better, can't get more chemo, your body just isn't cooperating like we'd like it to, and you end up coming in and out of the hospital? Can we talk about that? So I think things like plan A and plan B can be very helpful. I think time-limited trials. Hey, we're going to get you home and we're going to see how you do over the next couple of weeks. And then if you're stronger and you can get chemo, great. But if you can't, if your oncologist says, no, I'm sorry, you're still not a candidate for chemo, then let's have more of a conversation. So I think it is very nuanced even among healthcare teams.
So the healthcare team, like families, healthcare teams can also function like disagreeing family members.
Even more so.
Even more so.
Yes, absolutely. Absolutely. Yeah, you will see this because there's just different perspectives, right? Depending on different specialties and different relationships, and everything is about relationship. Right. So this patient's relationship to those around them in their family, but also to different physicians. And that makes a big difference. Yeah.
Thank you for that. Any questions here? All right. I do have one more online here. This will probably be our last question. Oh, we have a couple more, but let's see if we can get this one. What should happen if an agent is properly named in advance directive, but the healthcare professional team concludes that the agent is poorly motivated and is failing to actually represent the patient's best interests? Can the team remove the agent?
So again, that's really hard. I think some of the cases that we've seen is, let's say someone's been named as an agent 20 years ago, and that agent now has dementia and maybe not be able to do all the things that decision-making, that constitutes decision-making, right? So just like a patient, when you're talking about interventions, they have to show decision-making, and that's, I understand what my problem is, I understand the treatments you're offering, I understand the benefits versus risks of those, and this is what I would like, and it's a consistent wish over time that's consistent with their lived and stated values. If the agent can't do that either, then I think that's problematic, and we would have to say, I don't think that agent now is able to function in that manner. But But again, I am not an attorney, so we would then probably need to get some legal assistance, because is there somebody else? Is there an adult child who is willing to help make decisions, maybe even help that agent who's really not able to independently make that decision? Maybe a son or daughter could help them. And so you try to, again, kind of protect the dignity of that agent who may not be fully able to make those decisions, but you also make sure that someone is there to help with going through that process with them.
So I'm hearing that to have a lot of compassion for an agent, because this might be a very difficult time for that person.
Yep.
These last couple questions are actually really important. So if you need to log off, thank you for attending. We appreciate you being here. If you need to leave for your afternoon sessions, please feel free to do that. But there's a couple more questions here. Since one person asked, since there's no family hierarchy for an agent for a patient with no advance directive, how long does it take to determine who is to be the patient's surrogate and who chooses? Is it a judge or a healthcare professional?
So according to the law, the healthcare team can say, I'm listening to you. How long does that take? Very few healthcare teams will do that kind of on their own. They will usually ask for an ethics consult and say, hey, this family is fighting. Who do we listen to? So we would want to bring everyone together and actually hear all sides of that story and find out why there's conflict. And again, what we're trying to get at is who knows this patient the best and who is actually speaking on their behalf, not their own behalf. Because like with Donna's situation, you know, even though the husband is saying, let's keep going, often people kind of default to spouses, but that actually was not what she had wanted. And he's thinking more of their children. So you really want to have this conversation. And sometimes it takes many conversations, because often more family members kind of show up. A couple fly in from New York, right? One comes down from Washington, and it starts the conversation all over again. So I don't know that there's a perfect answer, but again, it's a conversation among all of them. Yeah.
Thank you. And last question here, Dr. Mohr, thank you for sharing on this essential topic. How can a healthcare organization create an environment of deeper collaboration around engaging patients and families in the discussion and presenting and discussing advanced directives? What does the ideal environment look like to you?
That's a great question. You know, if you look at Gunderson Lutheran in La Crosse, Wisconsin, they have a system. They actually have a clinic that is, I think, nurse practitioner run, that is only to talk to people with advanced illness and talk about their advanced care planning. That's it. That's all they do. So, you know, is that something that we can get all of our primary care physicians, all of our specialists involved in? You know, it would be nice, but right now primary care would say we have too many things to do. Specialists would say, no. If I bring up advanced directives, you know, they're going to think I'm giving up on them and I don't want to do any more surgery or any more chemo. It's probably not the case. So how do we as a system say this is just something important that all of us need to be engaging and having this conversation? I think it's a matter of getting all the stakeholders involved, who really range from nursing, right? Physicians, social work, chaplains, everyone across the board, and saying, how do we improve things here? Yep.
Thank you very much. Thank you for attending. And just a quick reminder, this will be posted on our website. Thank you.
Thank you all very much.